And good morning, I'm Dr. Duke Majan. It's May 23rd, 2023. We're streaming live spine surgery. Our first patient is having 3 discs in his lower back repaired. The number, thank you, the number 344551. He has basically annular tear with herniated disc at L3-4, 4551. At L3-4, it's on the right side, 5-1 on the right, and 4-5, it's on both sides. So we'll be fixing both sides at 4-5. I need you to lay still, my friend.
We took the horseshoe out. Maybe they'll be more comfortable.
Shot? All right. Making some progress. So the first thing we're going to do is access the discs that we need to fix. And the way we do that is using a needle, spinal needle. And that's what I'm doing right now. Our patient is awake, helping me. He's giving me some feedback, or will give me feedback. It looks like our orbit is bad on 5-1. You need to fix that. Shot? I think that's better. So the patient has a lot of arthritis at L5-S1. You could see it. I think that's better. Let's keep that. And because of the arthritis and the collapsing of disc, he has what we call scoliosis, where his spine is actually shifting. And Sean? Sean? Just give me a minute. I'm trying to access L5-S1. Sean? Where do you feel that?
Where are you feeling?
AP?
He's in the back.
Not down your leg, correct?
Try to keep your head really still so you have too much head.
You're moving around. We don't want you moving. Lay still.
You gotta get your head really. I've done everything I can to keep your head comfortable, okay?
All right. So at this point, we're in the first stage of the surgery, which is to place these needles percutaneously to the spine. At that point, we'll do a discogram to confirm the discogenic pain. And then after that, we're going to put him to sleep. Where do you feel that? You feel that in your back? Where is it? On your back? Not down the leg.
In your back or your leg? What's that? Not the leg, the back? The back. He said not the leg.
Yeah, I feel the bone spurs right there. They're pretty bad. There we go. Yeah, that's your bad disc, my friend. Lay still. All right, you're doing great, by the way. You're doing absolutely great. I need some more local. So our patients have to be awake for the lumbar and thoracic to help me, guide me, because we're in a really, going down a very narrow alley, so to speak. I'm going to give you some more numbing medicine, okay? Just relax. So this is kind of like when the dentist gives you numbing medicine on your gums before he starts working on your teeth. So we like to put a little bit of numbing medicine. And then my anesthesiologist told me I've got to wait a little while. How many minutes? 7?
7 minutes.
7 minutes, he told me.
That's textbook precise.
So we're going to wait just a few minutes here, and then we're going to make an incision. In the meantime, just to give you the lay of the land, he's got 3 discs that are problematic: L5-S1, L4-5, L3-4, okay? And these 3 discs are damaged. He has herniations. Other name for it would be spondylosis, slip disc. And then also protruded disc, ruptured disc. There's many different names for the same thing. It's basically a damaged disc. And at L5-S1, he's got a herniation on the right side. This is his right side. And this is the left side. And at L4-5, he's got herniations on both sides, pinching nerves. Lay still. Stop moving.
I'm moving.
You can't breathe.
Turn your head a little bit. horseshoe out, he's on a flat pillow. There you go. That's better.
What about, so the horseshoe is empty in the center, right?
Yeah, but we took that out because it was pressuring him, so we just went with the regular pillow, hospital pillow.
Okay.
We tried a couple things.
Sure. All right, just get him comfortable. All right, you're doing great, okay? Hang in there.
I think a deeper level of anesthetic and you won't mind.
Well, but we're not ready for that yet. Just give me a few minutes. So we're making a 7mm incision. Why don't you go ahead and show the audience, why do herniated discs cause back pain? Let's show them our educational video.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. Now you've seen why a annular tear, herniated disc, will cause so much pain. It's due to inflammation within the tear. And that's the #1 reason people get back pain, is inflammation within the annular tear. It counts for about 85% of back pain. The other 15% comes from other places, like the facet joint, which we're passing right now.
Try to keep your head still and your arm still.
You're doing great, by the way, Sean.
Yep, we're almost done.
Almost done. Sean? Give me an AP. So this patient has his back pain coming from the herniated disc. In the back of the disc, there's a tear in the back wall called the annular tear, posterior annular tear, and that's where his pain's coming from. So we're going to go in there today. We're going to repair that tear with a laser, clean it out. It's called an annular debridement, and that should do the trick. All right. Are you comfortable? So I'm happy with all the needles. I'm not happy at 5-1, but it could just be the scoliosis he has there. He does have some rotation between L5 and S1. You can see it's offset compared to the 3-4 and 4-5. And that's degenerative scoliosis, but it's not causing any symptoms for him. It just makes it difficult to get the needle in position, along with his facet hypertrophy. So there's a couple of anatomical issues there. Are you comfortable?
Yes or no?
Are you comfy?
Yes.
We're going to put you to sleep soon, and when you wake up, we'll be done, all right?
Thank you.
How long have you had back pain? How many years?
How many years? How many years?
He told us 5.
He said 10. Just now.
10 years. All right. Is he comfortable?
Yeah.
You doing all right?
He said yes.
He's able. All right. Are you having any pain right now?
Are you having any pain?
Are you having any pain right now?
Huh? No?
he awake enough?
He's just shaking his head, he's not answering. Hey, my friend, you okay? He said yes.
Are you having any pain right now?
No.
No? All right. How bad is that on a scale of 1 to 10?
0 to 10, give us a number. 6.
Is that where you typically get back pain?
Yes.
All right, so he has 6/10 pain. He's pretty stoic. It's concordant. That's at L3-4. Is it better now?
Better? Yes.
All right. L5-S1 is the one I'm worried about. Oh, look at that. It's very hard to see. Let's see. Shot? Shot? How bad is that on a scale of 1 to 10? Give me a number. What's the highest?
8.
Wow. That's 8/10 at L5-S1. Is that where you typically get your back pain? Is that where you get your back pain, my friend?
Yes or no?
Is that where you typically get your pain?
Yes.
All right. Almost done. Are you ready? Okay. How bad is that on a scale of 1 to 10? He's groaning. 10?
10.
All right, that's the L4-5 is a 10. Is that where you get your back pain?
Yes.
All right, so very interesting. L4-5 was the worst, 10 out of 10 pain. You can see him arch his back up when I injected. I didn't tell him when I was injecting. I don't want the patient to know when I'm injecting so I can get a real response without them being aware. And then L5-S1 was an 8 out of 10 and L4-5 was a 6 out of 10. So there's his pain map. We're going to put you to sleep. I want you to count from 1 to 100 out loud, okay? Yeah, what? Just count from 1 to 100. You're doing great. When you wake up, we'll be finished with your surgery. So we know for sure that the 3 discs are causing his typical daily back pain. And we know that it's a tear in the back of the disc that's causing that pain. And those 3 discs are the L3-4, L4-5, L5-S1 discs. In his case, everybody's different. The most common disc to cause back pain is L4-5, followed by L5-S1, and then L3-4. Now he also has herniations that are pushing on the nerves going in his legs, which is why we have to do both sides at L4-5. And finally, he is going to get his knee fixed today as well. He has bad knee arthritis. He's been recommended for a knee replacement, but he wants to try what's called the Duke plasma rhizotomy for his knee pain, which could keep him from getting a replacement if it works. We're still in the early phases, and he knows that. He's agreed to do it, despite the fact we don't have any long-term data. But we're very encouraged by the results of our first patient. Okay, any questions from the audience?
Yes, we have the first question comes from Darren on
I
Facebook.
want to do 3-4 first. Yes, go ahead.
They asked, how can someone mitigate back pain while waiting for spine surgery?
A great question. How could someone mitigate back pain while waiting for spine surgery? Well, the first and most important thing is to get the right spine surgery. And there's a lot of spine surgery done out there that will not fix your back pain. And so it can actually make it a lot worse. And you could see those stories online all the time, people having fusions or artificial discs or laminectomies or whatever. It did whatever surgery and it's not getting rid of their back pain. So my first piece of advice is make sure you're getting the right surgery to get rid of your back pain. And I'll be honest with you, when I talk about the right surgery, I don't just mean the right procedure. I mean having the proper areas fixed, because curing back pain requires the surgeon first identify the sources of back pain. And there's so many different causes of back pain. There's quite literally 30 causes. And those causes are not equal in frequency. In other words, some causes are far more common than others. Go ahead. And you want to make sure whatever is causing your back pain, that surgeon identifies the source properly. And I'll be honest, it's not easy to do that. It's hard. And a lot of surgeons don't know all the different causes of back pain. They don't understand the facet is the cause of back pain, the disc, and how the disc causes back pain. A lot of surgeons think deformity is the cause of back pain, but it's not. Deformity means kyphosis, scoliosis, listhesis. I used to believe the same. I was guilty of telling patients, hey, it's your kyphosis that's causing your back pain, or it's your scoliosis causing your back pain, or it's your slippage that's causing your back pain. But I was wrong. And I didn't know it at the time because I was trained to believe those things by my training. And I went to the very best neurosurgery training program in the world at the time. And the reason I did is because I was basically the #1 draft pick in the United States in neurosurgery when I applied, which was 1996. I went to a top medical school. I was valedictorian. I had research in different areas of neurosurgery. I had the #1 mentor in the United States and probably the world, Dr. Marty Weiss at USC, the chairman, who happened to also be the chairman of the Neurosurgery Residency Review Committee. So he was guiding me and supporting me. I ended up at the University of Florida in Gainesville, which he ranked #1 in the world for training. And they only take 2 doctors a year, and I was one of the 2. The other one was Paul Tolentino from Harvard, and he had gone to Harvard Med School and Harvard undergrad, and he was a 4.0 student, as you can imagine. So the 2 of us started at University of Florida in 1997, and I finished in 2004, 7 years later. And so I was very well trained, yet I was trained to do spine fusions, artificial discs, laminectomies, microdiscectomies, all the types of surgeries that I discourage people from having today. Even spinal cord stimulators, morphine pumps, we did it all. We were a top spine center. And all those techniques are still being used today, even though the field has advanced tremendously. So my advice to you is, #1, get the right surgery. And that's very hard to do anywhere else. Duke Spine Institute's one of the few places in the country that actually do the right surgery. And that's why our results are so good, okay, compared to other people. But to deal with pain in the meantime, I think you can do an epidural would be one option. Facet block would be another. Rhizotomy would be another for the facets. Anti-inflammatories, as long as you can actually take them. Some people cannot because they're either allergic or they have ulcers or they have kidney problems. Anti-inflammatories can be dangerous if they're taken by the wrong person. What's going on? You guys all right?
Yeah, it's good. Awesome.
Okay, good. Yeah, he's fine. So you can even keep him a little lighter if you want. Whatever is safe for the patient. But yeah, everything's going well. So just take a look. There's a piece of herniation there. The reason it's blue, we put a special blue dye, and the blue dye will only stain degenerative nucleus pulposus. That's the only thing it'll stain. So if you think about it, what's down here? You got nerve, you got annulus fibrosis, you got inflammatory tissue, you got nucleus pulposus that's normal, and then you have nucleus pulposus that's degenerated. And the blue dye will only stain degenerated nucleus pulposus. Everything else will not stain. It'll stay their natural colors. So inflammatory tissue is pink and white, mostly pink. Scar tissue is white. It won't stain blue. Normal disc nucleus will be white. It will not stain blue. It'll stay white. And the only thing that turns blue is acidic, spelled ACIDIC, because it has a pH less than 7.4. There's another piece of herniation. And these herniations and pieces of blue disc are bad. They're the cause of the inflammation causing pain. So Henry, let's show the audience what Duke laser disc repair actually does. How does it actually fix back pain and leg symptoms?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. a Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
I thought you'd laugh at that.
I don't know. Welcome, welcome back. We are in the middle of repairing the L3-4 from the right side. And I just wanted to show you guys, for those of you who've not seen this before, the laser fiber is that glass. It is made out of glass. It's not plastic, glass. And it transmits laser energy to the disc. And it's 1 millimeter wide. So just to give you an idea of how wide this is, it's about 5.5 millimeters from side to side. That's very small. And you can see how the laser really requires pretty much direct contact with the tissue to do anything. So that's why it's so safe, is you can actually see the tip, and it's not the side of the laser that delivers energy, it's the tip. So you actually have to touch the tissue to deliver the energy under these circumstances that I'm using. Now, if this was in a dry medium, in other words, in the air, for example, the laser would shoot out of the tip, of course, and it could go somewhere, and it could cause damage. It could shoot out, I don't know how far, maybe a few feet, I'm guessing. But because we're in liquid, a liquid medium, which is saline, sterile saline, we call it irrigation. The laser doesn't just shoot anywhere, it just literally stays, the energy stays by the tip. So the laser beam doesn't shoot around. Okay. Now you can see the annular tear right there, and you can see the blue stuff stuck in there. That is the source of his back pain. And by the way, look at that tear. It's actually right up against the end plate of L4. So it's at the bottom of the disc, bottom of the tear, the bottom of the annulus, rather than the middle or top. It's right at the bottom. But this is definitely an abnormal disc. I think he's going to be very happy with the results. This is all herniation. And we call this part of the herniation interposed. Interposed means between, located between. How's everything, Luis?
Very good, very good. Thank you for asking.
All right, any questions? So I hope I answered the other question adequately. You know, you can do shots, you can do some medicine for the back pain, but there's really no good treatment except for the surgery. Other things don't work. I'm not going to recommend you take narcotic painkillers because they're highly addicting, they're unhealthy. By the way, for those of you wondering, this surgery is done so minimally invasive, the patients do not require any post-operative narcotics. So no painkillers. Any other type of surgery like laminectomy, fusion, you're going to be taking painkillers for months, recovering from the actual surgery. The reason why you take painkillers for months after open back surgery like laminectomy, discectomy, fusion, artificial discs, is because those surgeries are creating so much trauma to your body. They're hurting your body permanently. And that pain from all that trauma is what you're feeling. I mean, if you're a soldier on the battlefield and you take a rifle round to the leg, it hurts, and you're going to be taking narcotics. The reason is that that bullet literally destroyed all your muscle, bone. Well, it's no different with spine surgery. The surgeon is doing that inside your body, unbeknownst to you. They don't talk about it to you because they don't want to scare you off. But I know it. I've seen it. And actually, we have it on our video channel. You can actually watch me do those surgeries from the past. Fusions. And you can see how traumatic they are. And by the way, my fusions are very atraumatic. That's why we can do them outpatient. People go home the same day. So imagine other surgeons doing them far more traumatically than what I do. If you go to our YouTube channel and look up spinal fusion, you'll see surgeries that I've done over the last 10 years. We broadcast all of our surgeries live on YouTube, Facebook, Twitter, and now LinkedIn. And you can go back and watch these surgeries on YouTube. They're indexed on our YouTube channel. Now, you may be able to do it on LinkedIn and Twitter, but I don't know how to do that on those platforms. I just know about Facebook and YouTube. And for me, YouTube's the easiest way because we've got everything indexed well. Henry does all that. He does a great job of doing it. By the way, Henry is your broadcaster. He's the one that asks me the questions and does the whole broadcast for you. He's the one bringing you all these powerful messages of hope. All right, Henry, what other questions do we have from the audience? We're almost done with this disc. Just a few more minutes to go.
Next question comes from Oz on YouTube.
Hi, Oz.
They asked, do you believe that minor car accidents, like under 5 miles per hour, can injure the spine?
Do I believe that minor car accidents under 5 miles an hour can injure the spine? The answer is they can. However, they would be injuring what's called a pre-existing injury, most likely. In other words, a 5 mile an hour impact, it can also hurt your spine, but most likely, if that person has pain as a result of a 5 mile an hour impact, then they already had a problem that just got aggravated by the accident. Now, from a causation standpoint, the accident is still the cause of the need for surgery and treatment. So it should be compensable by the carrier. It should be paid by the insurance company. They'll try to get out of it, of course. They'll fight it. They'll have their experts try to testify that the 5 mile an hour could not do anything, but it can, absolutely. And I would testify that it could. You know, the thing about medical legal work too is that this surgery lets me look inside your disc, and I can tell pretty much whether or not the disc injury is timing is the same as your accident. I can tell because I can see this herniation right here. I know how old it is. For example, this part right here is several years old. This is not recent. But if you gave me every car accident patient, I could figure out by being inside their disc with all my experience how old that injury really is. All right, we're done with this level. We're going to move on to the next level. Let me see if I can see the nerve. Well, the nerve is up there in the fat. Actually, I want to get a little bit more of that blue. Yeah, we're almost done. I'm sorry. Laser on. Okay. You're fine. All right, good. You're doing great. All right, good. So we're done with one disc. Moving on to the next. Good job, Oscar. We put a little bit of betadine in there. Betadine is an antiseptic. It doesn't do anything for pain. It doesn't take pain away. It just disinfects the wound in case there's something in there we don't want, like a piece of bacteria, or something, which we don't expect. But it's standard operating procedure. Have you guys heard that? That terminology, standard operating procedure? Where do you think that comes from? It comes from the operating room. It comes from surgeons. Surgeons do things in a standard way. Like when you take out an appendix as a surgeon, you do it the same way every time. And you do it that way because you get predictable results. So we call it standard operating procedure because the procedure is the same and it's standardized. We like standardized treatments. Standardized treatments mean you get predictable results for predictable diagnoses with the same treatment. Great question. So to answer your question, I do believe a 5 mile an hour impact could cause an injury to the disc, and I do believe that that injury could require surgery. Just wait.
Yeah.
All right. Let's do 4-5 next. 5-1's going to be tough. I want to save it till we're done. All right, Sean. You're too south. Help me with pressure. Uh-huh. Any questions from the audience?
We have a couple questions and a couple comments. This next comments come from Mick on YouTube.
Sean? Uh-huh. Hi, Mick.
And they said, wow, this is me, and I have a titanium in my back. I fell, broke a screw, then needed a left hip done, and my scoliosis got worse. I'm due for a new SS. I feel so complicated. Done. Even morphine and Percocet. Watching you, I have hope.
It's Nick, right?
Mick with an M.
Hi, Mick. Welcome to our feed. We can fix you with this surgery, most likely. And the reason I say that is your screw, I don't think your screw is necessarily the problem. I see a lot of people with broken screws, and their pain is not coming from the broken screw. It's coming not even from the segment that didn't fuse. It's usually coming from an adjacent segment. We call it adjacent segment disease. And it's very common in fusions when people get adjacent segment disease. All right. So my advice to you, Mick, is to send Duke Spine Institute your MRI through the link that Henry will put. It's called mri.dukespine.com, and get a free 10-minute meeting with me, Dr. Duke Majan. Get a diagnosis, what's causing your pain. Because the worst thing in the world you could do is have a surgery you don't need that isn't going to fix your pain. And a lot of people have those surgeries. You read about them on the internet. Happens all the time. You know, a lot of unnecessary invasive surgery. Okay, invasive surgery is done. A lot of unnecessary procedures that don't work. So we're not perfect by any means at Duke Spine, but we have a really good track record when it comes to fixing pain, better than anybody else. And the reason for that is, number one, we make the right diagnosis, and number two, we provide the most state-of-the-art, most effective treatments in the world that are the least invasive treatments with the fastest recovery. As I was talking about earlier, the reason why when you have open back surgery you have to be on narcotic painkillers is because the surgeon has done so much damage inside your body that your body is screaming in pain from all the trauma that was done from the surgery. Well, these patients don't have that. We don't have any pain after these surgeries, very minimal pain, and the patients don't take narcotic painkillers after these endoscopic surgeries. And that's true of not just Duke Spine, but that's true of all endoscopic spine surgery. Much safer type of surgery than open surgery. The problem is, the surgeons that do open surgery, they do it because, let's just be honest, it pays them a lot of money, okay? A lot of money. They get a lot more money. The highest paid surgeries are fusions. As a surgeon, you make the most money doing fusions and artificial discs, spinal cord stimulators. You make a ton of money. And so that's why they're recommending it to patients, even though they don't work. Even though those procedures don't work a lot of time, or they're unnecessary, they're still recommending them. So look at this tear right here with the blue stuff. This is a huge tear. The white stuff is the annulus, the blue stuff is the herniation, and it's just stuck in there, keeping the annulus from healing. And in particular, it's really bad right at the apex, what's called Camon's triangle, right where the disc, the back of the disc, where it comes together with the ligaments. The posterior longitudinal ligament, right here. You can see the tear. You can see some calcium on those fibers that are torn. And that's just from chronic inflammation. You can see a bone spur right there, the orange thing. And by the way, we're creating a new video animation at Duke Spine. We're going to be able to show you soon from our animator that's going to show you all these things that we find all the time when we do these surgeries that nobody else in the world knows about because they don't do these types of surgeries. A lot of endoscopic surgery that's done is done with just grabbers, metal grabbers, and they don't go actually into the tear and repair the tear. See the tear right there, all the torn fibers? We have to clean that because that won't heal on its own. The body has been trying to heal that for years, and it will not heal. It won't heal, just like if you know anything about what are called diabetic ulcers or arterial insufficiency ulcers. If you look those things up on the internet, you'll see what I'm talking about. That's where I got the idea to do debridement. It's from my training and my work with patients who had non-healing wounds in plastic surgery and in neurosurgery and orthopedic surgery. And I realized that there's these skin wounds and these soft tissue wounds that don't heal. And you have to go in and clean them up with with all kinds of stuff like bovies and sharp knives, and you got to clean all that stuff out, and then the wound will heal. So, but that's skin and it's soft tissues, right? Soft tissues like this right here. The disc is a soft tissue. So when I started thinking about the disc and the annular tear, I realized, hey, the annular tear is having trouble healing. That's why people have so much back pain, because their body is trying to heal that tear through inflammation. Inflammation is how we heal things. So they're trying to heal it. It's a tear. They got it from trauma. They got a herniation. They're trying to heal it. It's making all this pain in their back or neck. And you know what? They can't do it. And they need some help. So this is a hidden non-healing wound, right? Because the stuff on skin is easy to find. Like diabetics, they have these big ulcers on their legs. People with venous insufficiency have big ulcers on their legs, arterial insufficiency, and those ulcers never heal. And you got to literally put them in special treatment like hyperbaric oxygen, debridements where you clean it out every week, special medications with antibiotics. There's all kinds of stuff you have to do to get those things to heal. Well, this is the same thing, except it's inside the body. You can't see it. And nobody's ever thought of it before. They never put two and two together. And that's how I figured all this out. I drew upon my past experience. And I started doing these procedures, and lo and behold, the patient's back pain went away. And I realized, hey, I'm onto something here. So it all made sense. Still does. This is how people are going to have their spines fixed in the future. Unfortunately, because I'm the only one doing it, it takes time for this knowledge to spread. See the calcium right there? It's turning orange with the laser. Yeah, thank you. Anyway, next question.
Next question comes from Severin on YouTube.
Who?
Severin,
How do you spell?
Severin.
Hi, welcome to our broadcast.
And they said, does DLDR never require drilling in the spine due to insert the endoscope?
That is correct. We never require drilling. Nope, it's always done with a needle. The needle is key. That's why the patient's awake in the beginning, because I need to navigate that needle right through the neuroforamen where the nerves are, right past those nerves, just below them, and lateral. So we never drill, we just use the needle. There's no reason to ever drill. In 16 years I've been doing this surgery, I've never had to drill. And I've always gotten rid of the leg symptoms and the back pain from the disc. Great question, great question. Let me try a grabber. So we're right at the back of the disc now, we're almost done. This is the L4-5 on the patient's right side. We're going to be doing the L4-5 on the left side in a minute. But now I've come to a place where I need to see if I can grab any of this herniation out with a grabber. So I'm going to take the laser out in a moment, and I'm going to bring my pituitary rongeur and try to grab out some of that herniation right there. Okay? Great questions, by the way. Keep them coming. By the way, you can see a little bit of fat up there at 12 o'clock. That's in the epidural space. That's at the back of the disc. That's right where the nerve root, the traversing root goes, past, just right there at 12 o'clock. Okay. I'm going to bring the laser back in, clean things up. By the way, you can see how ineffective the grabber really is. It's not very effective at all with dealing with these areas because the tissue is so tough, it can't come out with the grabber. The only way to get it out is to use the laser first, free it up, break it up into little pieces, and then get it out.
We have another question.
Sure.
This comes from Mick, once more, on YouTube.
Hi, Mick. Yeah, no problem.
They ask, what if my injury was 8 years ago? Can you still fix my back pain, or am I too fused and too many adhesions at this point? And can you fix more than one disc? After my fusion, I fell off a hammock a year later.
Yeah, Mick. So these big questions. Number one, we can definitely fix your back pain. There's nobody in the world that can do it better than we can. We can fix it. Number two, I don't know exactly what you need done, like precisely. I could tell you, but I need to see your MRI, your X-ray, your broken screw, etc. I need to see that. So if you do a consult with me virtually, we do it over Zoom. It takes 10 minutes. I could figure everything out in 10 minutes. If I can't, I can order some tests to be done, and then I could meet you back again virtually. The point is that to know exactly what treatment you need, I just have to see your current MRI, current X-ray or CAT scan, and I will tell you exactly what needs to be done to get rid of your back pain. Okay, but I'm 100% confident we can do it. Great, it's just about finished. There's just a little bit of disc herniation left. Trying to get it. Oh, by the way, another thing. I get this question a lot, and it's important that people understand this. No surgeon on earth can remove 100% of a disc herniation. Okay, the best we can do is 90%. That's the very best, and that's rare. You almost never see 90% of a herniation removed. And the reason is that you're working on something that's kind of deep and big, and it's not in one specific location. Like what we're seeing right here is not the whole disc. You're literally seeing like a pea size. It just looks blown up and magnified, right? But the reality is that the whole disc is huge. It's about 20 times bigger than what you're seeing, maybe 30 times bigger. Okay? So yes, it looks like we're getting everything, but at the same time, you never really do. And that's not important. It's not important to get 100% of every herniation. Remember, people live with herniations for years without symptoms. So it's only when they become symptomatic that we actually treat them. Grabber? Just want to get this last piece. So what causes a disc to become symptomatic? Well, there's two things. One is inflammation, and the other is compression. When the disc herniation puts pressure on a nerve, then you get, then you get the leg symptoms like weakness, numbness, and tingling. But the pain itself, sciatic pain, back pain, that comes from inflammation. And inflammation doesn't have anything to do with the size of the herniation. It has more to do with the location of the herniation. And so removing the part of the herniation that is causing the inflammation, that's the most important thing to do if you want to treat leg pain or back pain. And that's why I'm able to target such a small area. And even though I don't get 100% of the herniation, I'm able to get rid of the symptoms because I'm treating the exact spot where the pain comes from. Does that make sense? Next question.
No current questions.
There's nothing else in there that's loose. It's all good. Let's see if I can get a little bit more. All right. In that case, for our late arrivals, why don't you run the video showing how the Duke laser disc repair actually works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We have now completed 2 discs repairs on the right side. We have 1 more to go, just wait. And we have 1 on the left, and then we're going to be done with his back. Now people ask me, what causes back pain? And I tell them the most common cause of back pain is a herniated disc. And you may not see the word herniated disc on your MRI report. You may see protruded disc, bulging disc, slip disc, ruptured disc, extruded disc, but there's many different names for the same thing, okay? And they're all the same thing. They're basically, even degenerative disc, basically an injury to your disc. And people try to make it so complicated, I don't know why, because the truth is, the disc is very simple. It only has really 2 parts. I don't count the end plates as part of the disc, but it has an annulus and a nucleus, okay, normally. So when you get a tear in the annulus from trauma, some kind of an accident, that's when all the trouble starts. So trauma is always the cause of herniated discs, always, 100% of the time. The question is what is the trauma, right? So is it like a car accident? Is it a slip and fall? What caused the trauma? And that's different for every person. But the reality is that the trauma is the cause. Okay. Then after the trauma, you get a tear. That tear doesn't cause pain by itself. You must have a herniation. The herniation is when the nucleus material goes into the tear and causes inflammation. That's it. If you don't have the herniation of the nucleus material into the tear, you will not have a bulging disc, you will not have a herniated disc, you'll not have a protruded disc or a ruptured disc. You will not have pain or symptoms. Now, if you have a tear in the wall, the annulus, and it heals before you get a herniation, great. You can avoid a herniation, and you can avoid degenerative disc disease, which will occur over time. You can avoid the inflammation. It's the inflammation that destroys the disc. Nobody knew that until we discovered that at Duke Spine. Everyone says nobody knows what causes degenerative disc disease. Nobody knows. Well, what we do know is it's inflammatory. It's inflammation, okay? And where does that inflammation come from? Well, it comes from the posterior tear, okay? It's being angry or angered by the nucleus pulposus. And that nucleus is herniated into the tear. Once the nucleus gets stuck in the tear, there's no coming back. It cannot go back in. I get a lot of people asking me, hey, Dr. Duke, what do you think about this chiropractic treatment where they put you on a table and they distract you? It's called VAXD, disc decompression, disc decompressor, whatever you want to call it. They have different names. It's all the same thing. That machine will never put your disc back in. And besides, you never want that disc to go back in because it's damaged. It's bad. It's like... It's kind of like if you have meat in your refrigerator and the power goes out and it defrosts and rots, and then you turn the power back on. Do you want that meat still in your refrigerator? It's bad. It's destroyed. It has to go. It's permanently damaged. There's no fixing that. And these chiropractors, they're not all bad, by the way. I don't have anything against chiropractors. I have something against lying and cheating people. And it doesn't matter if it's a neurosurgeon or if it's a chiropractor who's lying and cheating. I don't care. In the end, it's somebody fucking things who's doing things wrong, in my opinion. I think patients deserve their doctors to be honest with them and be truthful. And the fact is that the VaxD machine will never fix your disc herniation, ever. And that pain will go away on its own, even without that machine. It just naturally, as long as you take it easy, good biomechanics, body mechanics, avoid heavy lifting, bending, twisting for a little while, you will allow that disc to potentially heal on its own, and the symptoms can go away on their own. But see, once you're enrolled in that program and you're paying and you're going in every week, you think that machine is fixing you, but it's not. That's just your body healing. And the thing about herniated discs is either your body's going to heal or it's not. You know what I mean? And the thing is, if you look at the natural history, what naturally happens with a herniated disc, a lot of them heal temporarily. They never completely heal, but they feel better because the inflammation dies down, and then they come back again. And they come back with activities, right, when you get active. So that's a problem. That's what we want to fix at Duke Spine. We want to fix your disc properly so that it heals completely and you never get that pain coming back again. The only way to do that is with the Duke laser disc repair. What do other surgeons do? Some of them will do fusions. So avoid your fusions. Get this done. It's much safer, much better for you. It's outpatient. You don't go to the hospital. You literally come here, get the surgery for an hour and a half, take an hour and a half recovery, and you go home. There's no hospitalization. There's no morphine pump. Look at the inflammatory tissue at 5-1 here. Wow. See the pink stuff? It's kind of hard to tell, but it's there. Okay, this is the back of the herniation. We're almost done. Got maybe another 5 minutes at most here. And then we're going to move on to, there's herniation. We're going to move on to the other side. So far, we've had some good questions today during the surgery. Anybody else with questions?
No current questions.
You guys know everything, huh? All right, good. That means I've done a good job of teaching you. See how that herniation there is calcified? Some bone spurs. People ask me about bone spurs. They say, can the laser get rid of bone spurs? Of course, just did right there. Those are all bone spurs. I just shaved them off easily, like no problem. That's like asking, can Conor McGregor beat up an 80-year-old lady? Of course he can.
Did you watch his biography? It's pretty good.
I haven't watched it. I see it's on Netflix. I don't know. He's doing steroids now, I think, and I'm not really a fan anymore.
I don't think he's fighting.
Well, he's talking about getting back in, but maybe he just wants to win in a different weight class, you know? I mean, I understand his point. Everybody's doing steroids, right? So why not? But that's not how I was brought up. That seems to be the prevailing mentality of people these days. Everybody's doing this bad thing. Why don't I just do it? All right, just about done here. Once again, we're at L5-S1 on the patient's right side. And this is the last of the herniation. I'm going to move over to the left side next and finish his L4-5. We were going to do a bilateral L4-5.
We have a question.
Yeah.
This comes.
By the way, 5-1 is the hardest level to get to traditionally for endoscopic spine surgeons because of the anatomy of the patients with their iliac crests, and the foramen is so tight and the facets are so enlarged. All those things contribute to making it very difficult anatomically to fix this area. Yes, Henry.
This comes from Darren once more on Facebook.
Uh-huh.
They asked, "What are your thoughts about chiropractors?"
What are my thoughts on chiropractors?
Correct.
Well, I think chiropractors are good as long as they stick to what they're supposed to do, which is adjustments where they adjust your spine, and I think they're very helpful. But they're not going to fix a disc problem, and that's where they overstep. You know, when somebody has a disc problem and they have discogenic pain, they're not going to be able to fix that. They need to refer that patient. And I think a lot of them don't want to do that. And I don't like chiropractors that try to sell patients on things that have no chance of working. And then they sell them on these, like these digital motion x-rays, and they show them that they're, you know, that they have these C1, C2 malalignment, like they're a spine expert at C1, C2. Please. Okay, they're not. Neurosurgeons are. And you know, they're just basically, the patient is laying in a machine with their head to the side a little bit and their spine is rotating, and they're saying, look, it's abnormal. It's not abnormal. So I guess I don't like the fraudsters, but there's a lot of fraudster neurosurgeons. There's a lot of fraudster pain management doctors. So I'm not picking on chiropractors as being exclusive fraudsters in healthcare. There's a lot of fraudsters in healthcare. So I mean, that I can't really hold against them, but just be aware that I think they're good, but just be aware that they do things sometimes that they shouldn't be doing. And I don't agree with that. Some of them do, not all of them. There's some really good chiros out there. My sister is one of them. She's a chiropractor. She's very good. She's honest. She doesn't do VaxD. She doesn't try to sell people on treatments that don't work. All right, that's pretty much it. I'm fighting the facet. That's it. That's it for this side. The nerve is going to be right there in that material. All right, all done here. Do you have any more questions? Scope off?
Yes. This next one comes from, love the name, Mama on YouTube.
Nice.
And they ask, is your treatment the same as the Yes treatment that Anthony Young did 20 plus years ago?
Oh, nice. No, my treatment is not the same as the Yes treatment, though I learned a lot from Dr. Anthony Young. He's my mentor, and he's a wonderful man. I don't think this is declogged. You did? Dr. Young developed what's called the Yes treatment, which I studied and was trained on. And a couple of things. Number one, he uses the same needle approach. He does a discogram. He does a transforaminal procedure. It's just, I guess, strange. He does a discectomy, like he takes the herniation out, so we call it really a herniectomy. So he does a lot of the same thing, but he does not use the laser. He does not use the laser at all. Therefore, he does not do an annular debridement. The laser is essential for the annular debridement. If you don't do the annular debridement, you're not getting rid of back pain and you're not preventing future herniations. So the annular debridement is absolutely essential to curing back pain. Now, he would always treat leg pain or leg weakness, numbness, tingling, but back pain is something that requires additional treatment like I'm talking about. It's called an annular debridement. The other thing is that we do thoracic and we do cervical here. Dr. Young does not. He only does lumbar. So his yes procedure is just for the lower back. Louise, come on over here and hold this, please. So the yes procedure is for lower back, for lumbar disc herniations, whereas the Duke laser disc repair is for cervical, thoracic, and lumbar, and treats back pain, neck pain, thoracic pain. Great question. Great question. I love Dr. Young. He's, to me, the greatest spine surgeon I've met in my entire career. He is a personal friend, mentor, advisor. He's a very interesting man. He's a pioneer. He's a great, great man and a great patient advocate. So, you know, there's few doctors in the world that actually want to do what's right for the patient. And he's definitely up there. That's what guides his treatments, is his desire to help patients get out of pain. And he's an honorable man, in my opinion. I can't say enough good things about him. I could go on all day talking about him because he's such a profound influence in my career and how I've treated patients. He's taught me so much. He's taught me more than any of my professors at University of Florida in Gainesville. He's taught me more than all of them, you know, especially about the spine. He's taught me things I never dreamed possible. So his yes technique, though, does not incorporate the laser. He uses a bipolar sometimes. It's called the Elman bipolar. It's not very effective, in my opinion. He does use shavers from time to time. I don't. I don't use a bipolar. But the tubes are similar. I don't use his yes tubes, his yes endoscope. He does have his own endoscope, by the way. The yes endoscope, I don't use it. I think this is a better one. I shouldn't say that too loud because he might hear about it, but he already knows I don't use the yes scope. He doesn't get royalties anymore from it. I think his royalty stream ended a couple of years ago, but this is a better system in my opinion. This is the vertebrous system, by the way, in case you're wondering. And it came after the yes scope. It was developed by Dr. Sebastian Reuten, who's a German spine surgeon, another one of my mentors and one of my favorite people. He practices in Germany. He's an endoscopic spine surgeon. And Dr. Reuten developed and designed this scope from the yes scope. So he took Dr. Young's design and then made changes. And this is the scope that the company is promoting now, is this particular system. In a way, they sort of cheated Dr. Young, but you know, that's political. I don't get involved in the politics. You know, I just use what I think is best. But anyway, that's my answer for you. Almost done, probably 10 minutes, then we're done. Then we're going to turn the patient, and he's going to get his knee treated with the Duke plasma rhizotomy. Yes, you have another question?
We have about 4 questions. This first one comes from Jeff on Facebook.
Before you say that, I just want you guys to see this. This is a really big tear. This is the left side at L4-5. Huge tear. Huge. I mean, look at the width of that thing. That's a bad tear. Bad tear and herniation. Sir, sorry, go ahead with Jeff's question.
He asked, is the patient snoring?
Is the patient snoring? Yes, they are, right? He is. That's him. That's not my team. That's not the anesthesiologist snoring. That's the patient snoring. Yes, he is. He's happily asleep, by the way, and he won't remember any of the surgery. So before I go any further, I'll just tell you guys, a good anesthesia does 3 things. Well, 4 things. The first is you're asleep, so you're unconscious. The second is you don't remember anything. It's called amnesia. You don't want to remember the surgery. So, you know, we use Versed to do that, I think, right, Dr. Berndes? He says yes. We use the propofol to put the patient to sleep. Yeah. And then the last thing is something called analgesia, which is no pain. So we don't give pain medicine, really. We give very little. What we're giving mostly is sleepy and amnesia. And I do some local. And Dr. Berndes just does a little bit of fentanyl, like a little sniff of fentanyl, which wears off very quickly. It's gone within a few hours. So, and then finally, the last part of anesthesia that makes it good is no complications. So, for great anesthesia, you want amnesia, analgesia, unconsciousness, and no complications. Would you agree?
I would agree. That's the definition of it.
Yeah.
And the perfect balance between analgesia and amnesia.
Yeah, exactly.
Well, we have the best infusion pump in the world, so
Yeah,
it's easy to infuse the patient safely with propofol. So
exactly. Look.
well, they're getting the right dose for the right body weight. That's really important.
Yeah, I'll tell you what Dr. Berndes has said, but look at this. See the inflammatory tissue there in the crack, that pink stuff? That's where his back pain's coming from. And that's spreading to the nerves, causing leg pain. All right, Dr. Berndes was talking about how having obviously a well-trained anesthesiologist is very important, but the anesthesiologist, just like me, I need the right equipment. I need the best equipment to do the best surgery. So we're very selective about the equipment I use. Every single thing I have has been sourced precisely to the best optimal physical parameters. And Dr. Berndes was just talking about how we have here at Duke Spine Institute some of the best anesthesia equipment available so that the patients have the best anesthesia experience as well.
I was on staff at 14 hospitals and 28 surgery centers. I never saw one location as better equipment.
Wow, that's incredible. He just said that he's been on staff over the years at 14 hospitals and 28 surgery centers? 28 surgery centers, and he's never had such good equipment as he has here at Duke Spine. That's quite a compliment. Then again, I told him he can buy whatever he wants and needs, so I hope he gets everything he wants and needs. You know, he has free reign. He's in charge of all the anesthesia here at Duke Spine, and I do what he tells me to do when it comes to the anesthesia. All right, any other questions? Just about done. Are we letting Dr. Patel know? I have 5 minutes. We need to let Patel. Okay, yeah.
We should let them know we have
You know what I want to do? I think we should put a stitch. I'm going to put a stitch on this guy. Just because he's so muscular, you know? I'll get the stitch. We have it?
We have the station.
Yeah, Henry, sorry, go ahead.
Next question comes from Mick once more on YouTube.
Yes, Mick.
They asked, does weight matter for your surgeries?
Does weight matter for my surgeries? Mick, great question. The answer is yes and no. First of all, I don't turn anybody away based on weight, but it will make my surgery harder for me. And, you know, we've had, I think, 2 patients because of their weight that I wasn't able to do the whole surgery I wanted to. I wasn't able to get the L5-S1 because the equipment wasn't long enough. So yes, it can matter if it's like 450 pounds, but anybody that's like under 400, I don't think it's a problem, right, Luis? And our operating table will take up to 450, right?
Yes.
Yeah. So our maximum for this table is 450 pounds. That's per the manufacturer's specifications. So I don't know, if somebody's 600 pounds, we can't operate. They're gonna have to get a gastric bypass procedure or a gastric banding and lose weight and then come here and get it done. But generally, unless they're over 400 pounds, we don't worry too much about the weight. It makes my job a lot harder, but like I said, I don't mind. My goal in life is to help people get out of back pain. So even if I have to suffer with a harder surgery, it's okay. I'm not selfish. I'm not here just for myself. I want to help people get out of pain. So I don't know if that answers your question properly. There's some more inflammatory tissue. Okay. Patel's already here?
No.
All right, just about done. So here's what I'd like to do. Any other questions, type them up. I'm going to come and answer them for you face to face, all right? But we're pretty much done here. I need one more minute. He's starting to wake up. I can feel him waking up, and that's fine. I just want to get this last thing done. Type up your questions. I'll come answer them for you face to face. We're going to be done in just about a minute. I just need to finish cleaning this and that, and we're done. And for those of you who don't know, the laser is the glass thing. You see, looks like a, I don't know what you call it, a glass fiber. It is a glass fiber, actually. It's a fiber optic fiber. So same thing that you guys get your cable service through, the undersea fiber optic cables, that's what this is. Except I don't think this is quite as high quality as the fiber optic cables are. I think those are even better quality. All right, I think we're done. Let me just try a quick grab, see if there's anything left, and we're going to be done. Quick grab. One more laser. And we're pretty much finished here at 4-5. We fixed both sides. And 30 seconds. Type your questions up. I will answer them, I promise. Just not right now. And Henry, you're welcome to go to a testimonial if you'd like and share the experience of one of our patients with the audience. Thank you. All done. And good morning, I'm Dr. Duke Majan. I'm here with one of my lovely patients from Canada who has visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years.
Yes.
Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair, endoscopic surgery, and you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, I've been in a very long time to be able to stand up straight and go for a walk, because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was. You said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, And that's end goal, and I feel like it's a possibility now.
Absolutely.
To do it.
You can.
Yeah.
We're rooting for you.
Mm-hmm.
And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's very hopeful, and if there's you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports in the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right.
Thank you so much.
Congratulations.
Thank you.
All right. Take care. I'm Dr. Duke Majan. I'm here with one of my patients and friends who I've known for years, and she has been suffering with back pain for, well, I'll let her tell you how long. And a week ago, she came and had the Duke laser disc repair. She's here for a checkup, and I'll let her tell you how she's doing as well. So how long have you had your back pain for?
Started back in May last year, and I just couldn't get any relief from anyone. Finally, I asked you, and the rest is history. So this last week has been the best week of my life since May of 2022. So pain-free.
Excellent.
Yeah.
Now, I know it got bad last year, but did you have back pain on and off before that?
I did. I actually got thrown from a horse back in 2018 in Ireland. And that's what I think probably started it. I was having lower back pain, but never really did anything about it, just sort of lived with it.
Kind of modified your life, took
Yeah.
it easy, try to avoid things that aggravated the pain.
Exactly.
And now I know that you were suffering so badly before the surgery, and here you are with a smile on your face.
Oh yeah, definitely.
Well, I'm so happy you're out of pain. You had the Duke laser disc repair. You could actually see, we use a laser to clean the tear in the back of the disc where the pain comes from. The problem is most doctors don't know that's where the pain comes from, so they have no idea how to fix it. My years of doing endoscopic surgery taught me that that's exactly where the pain comes from. So it's a small little spot in the back of the disc. You fix that, the back pain goes away.
And it worked.
It's amazing.
It's like I told your wife, you're a miracle worker.
Oh, thank you very much. Is there anything you want to say to your fans out there?
I just highly recommend if you've had back pain in the past, don't live with it anymore. Call Dr. Duke. He is the best.
Yeah, so many people's lives are just, quality of life is ruined by back pain.
It is, and not worth it. I'm ready to start traveling again, so.
Not too much too soon.
Not too soon, I know.
All right, very good, Jean. Great to see you.
Alrighty, thank you so much.
You're welcome.
I appreciate it.
Great to see you.
You too.
And I'm Dr. R. Duke Majan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on. And then You know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer, going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to
I'm
help
happy.
you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my
So you
community.
want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith
I
and
am.
you found us.
Yes, I
and
did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do
good.
for me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
Takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Good morning, I'm Dr. Duke Majan at the Duke Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Duke laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months.
And I'm I'm Dr. Dugmajan. I was just with you in the operating room, operating on this patient who has traveled from Texas to Florida to have his lower back fixed. And he's a smart man. He knows what he's doing. He was offered fusions. He didn't want it. Let's just stop making noise. And he basically came to Florida to have his back and leg symptoms treated. He also has a bad knee, and he decided he wants to go for the Duke plasma rhizotomy, a new treatment we're doing at Duke Spine for knee pain. Still very early on. We've only had one patient. He will be our second, but he understands that. He wants to give it a try, see if it fixes his knee. He said the worst case scenario, he's going to have his knee replaced anyway. So Dr. Patel is going in there to do the Duke plasma rhizotomy to fix his knee pain. All right, we have a bunch of questions, so we'll get right to it.
First one comes from Jerry on YouTube.
Hi, Jerry. Welcome.
They ask, what is the recovery time for this patient to be out on the open water in a boat?
What is the recovery time for this patient, the one we just did, to be out on the water in a boat?
Yeah, be out in the open water.
In the open water, I mean, you can go tomorrow fishing. You know, just don't pull in a marlin, right? Or a shark or something big. So basically, when patients have the Duke laser disc repair, they can go back to normal activities the next day with a few exceptions. So one of the restrictions is no lifting over 25 pounds. So obviously, if you're doing some light casting and fishing, it's not a problem. You can go on a boat, no big deal. Obviously, no chop. I don't want you bouncing up and down, falling on the boat. So as long as it's smooth sailing, it's no problem. And then the other restriction is no bending over at the waist, lifting anything heavy, or picking anything up, like a big fish, for example. So no problem. You go fishing the next day.
Next question comes from Nick once more on YouTube.
Hi, Mick. Got some good questions from you today. Welcome to our broadcast.
They asked, do you believe in chiropractors using these new stem cell laser machines? They call it stem cell therapy.
Jesus Christ. Sorry. Did I say that out loud? Of course not. Chiropractors are supposed to be manipulating your spine, not doing bullshit procedures like stem cell lasers procedures. Absolutely not. No. Chiropractors have a very important role. The problem is they don't get paid any money for what they do, and there's too many of them. So what they're doing is they're looking for these fancy name treatments that don't actually do anything but extract money out of your wallet. Sorry, I don't agree with them. I don't believe in them. I wouldn't recommend them.
Next question comes from Darren. These next two come from Darren on Facebook. And the first question is, wouldn't the patient naturally have amnesia because they're asleep?
Great question. So wouldn't the patient actually have amnesia because they're asleep? That's a great question, Darren. The answer is not necessarily. So sleep is an interesting thing. I mean, there's light sleep and there's deep sleep, right? So if you're in REM sleep, which is rapid eye movement sleep, deep, stage 4 REM, you're probably not going to remember what's going on around you. But the reality is we're not really putting them into deep sleep, because if you get them too deep, they stop breathing, the patients do. And therefore you have to have a tube and a ventilator and breathe for them. We don't want them that deep. This is twilight anesthesia, meaning they're not completely asleep. And the truth is there's no magic pill you give and then the patient hits twilight, perfect twilight, and stays there for hours. It's a titration, meaning the anesthesiologist is constantly giving a little more, like a little squirt of propofol, a little more. He has a machine that titrates it, and he kind of presses it and gives it a little bit more depending on the level of consciousness of the patient. So the reality is that patients could be awake and remember it. Heck, I remember I had a colonoscopy once, and I was supposed to be asleep with propofol, and I woke up during the procedure when they took a biopsy. Man, that hurt. So there are certain times during the surgery where I'm going to create more pain on the patient's back during the surgery, and they may actually wake up, but we don't want them remembering that. That's why we give Versed. Pretty standard stuff.
Next question comes from Darren once more, and he asked, what are some common reasons insurance companies deny coverage for DLDR?
So what are some common reasons insurance companies deny coverage for Duke laser disc repair? The most common reason they'll cite is they'll say it's experimental or investigational. And they'll use as the basis of that, they'll say there's not enough medical literature out there proving that it works. The problem with that argument is that all of the surgeries we've done in neurosurgery, brain surgery for tumors, radiation, I mean, everything we do as doctors doesn't have strong scientific studies to prove it. We never needed it. The only reason we need it now is insurance companies want it. And the real reason is they just want an excuse not to pay for your medical care. So they create an impossible set of tasks for doctors to jump through hoops in order to get paid. Look, if the insurance companies had their way, they would call everything experimental. And by the way, they're moving in that direction. I don't know if you know that. People are having a harder and harder time even getting MRIs, X-rays. They say they're not medically necessary, it's experimental. Ridiculous. So we don't believe the insurance companies, we fight them. In the end, a court of law will decide whether they're correct or not, whether they have the right to deny your surgery or not.
Next one comes from 22 Air Jordan on YouTube.
22 Air Jordan, nice.
And they ask, could this really be possible?
Could this really be possible? Yeah, the surgery is real. We've been doing it now 16 years, and we've been broadcasting it live just like this, so you can see the whole thing for 10 years now here at the Surgery Center of Viera, Duke Spine Institute. So if you go back, you'll see thousands of surgeries.
Next one comes from Darren, once more, on YouTube, Facebook, and they ask, what kind of back brace do you have patients wear afterwards?
Yeah, Darren, we have our patients wear something called an LSO, a lumbar spine orthosis, a lumbosacral orthosis, and basically it's just to prevent them from bending over forward and picking anything up.
Next one, last but not least, from JJ on YouTube. They ask, why does it take 12 months for the disc to heal after the procedure? I've heard docs say after 3 months you can return to normal activity.
That's a great question. So the reason it takes 12 months for the disc to heal is that it doesn't have a very good blood supply. The disc is one of those tissues in your body that we call it poorly vascularized. And so because of that, it heals very, very slowly. As a matter of fact, if you look it up on the internet, you might find that the entire center of the disc and the inner 2/3 of the annulus fibrosus has no blood supply at all. So all the nutrients that get to the disc come from diffusion. There's a reason that they don't have a blood supply, because the nucleus is extremely inflammatory, and if there was a blood supply, it would be under inflammation all the time, causing pain in everybody. All right, great questions. Thanks for joining us. We'll be back in 30 minutes for another surgery. Have a great day.